decline which can occur in patients who are mid-term survivors, who survive more than 4 to 6 months. We do see this in our patients. Other things that affect quality of life would include alopecia and fatigue. So the cost of neurocognitive toxicity drove us to use more precise radiation techniques to treat these patients. And here comes stereotactic radiosurgery. So this is a technique which is quite widely available now. There are different platforms to actually deliver this, be it the Gamma Knife system, the CyberKnife system, or LINAC-based systems. They all can be used. They're all tools. And basically, what they do is deliver a high dose to the tumor and spare normal tissue as much as possible. And this is particularly useful in the case of limited brain metastasis. And the evidence also suggests that in patients with limited brain metastasis, we can actually just do SRS alone and spare them whole brain RT without compromising their survival. And this is what we adopt in our institution most of the time. So this slide is too busy to look at, but what I wanted to point at is we have a protocol for brain metastasis that we follow. And in our protocol, we tend to limit it to 10 metastases or less. And that's for most of the patients. But my point I'm trying to make is that we're not limited by the protocol. There are some patients with very good function and very small metastases, but numerous. And we have also offered them radiosurgery in that context. For example, this paper talks about patients with more than 20 metastases. We call it the Club 20. And actually, this group of patients actually had pretty decent survival, even if we just did radiosurgery alone and spared them whole brain RT, with a median survival of about 9 months. And even when they recurred and they had a good performance status, we can repeat the radiosurgery again. So proton beam therapy is the other technique that we can use to be more precise, more in the glioma setting, and also the pediatric setting. And the real advantage, as has been alluded to by the previous speakers, is that the proton particle has got a finite range compared to the radiation beam. And the ideal clinical scenarios where this is useful for would be, like I mentioned, pediatric tumors where they have a long survival post-treatment and we want to minimize late effects. Certain skull-based tumors where we can actually spare the temporal lobe and, for example, the dose to the pituitary gland. And certain other skull-based tumors where dose escalation makes a difference. I think these are the real cases where proton beam therapy shines over the conventional radiation. So in Singapore, we are quite lucky. I would say we're a bit over-serviced. So from east to west, we're only 50 kilometers. But within this small island, we actually have 6 proton rooms. 3 facilities with 6 proton rooms serving a population of 5 million. So in a way, we are not the early adopters of proton therapy, but in terms of proton therapy per capita, I think we're a bit over-serviced now. But our ministry is cognizant about the rising healthcare costs. So they do sort of regulate which patients would benefit from proton therapy. So even though paying patients, they want money, they say, I want proton therapy, I think the ministry is a bit more circumspect now, saying that the benefit is little in that case, but proton therapy is not required. So these are the approved list of indications for proton therapy within the context of neuro-oncology. So they must have curable conditions, and they must have at least a life expectancy of at least 5 years. The other thing which possibly is a game changer, although it's not widely available, is MR-guided adaptive radiotherapy. So taking into context the case of glioblastoma, we usually design the radiation fields up front, and we assume that the cavity doesn't change in that 6 weeks of treatment. We give a 2 centimeter margin, and we just assume and hope that things remain stable for 6 weeks. But actually, when we integrate the MRI to the LINAC, we actually see the cavity dynamics. And the group from Sunnybrook in Canada have actually shown that the cavity dynamics it changes quite a bit week on week while the patient is on treatment. And what they have done is actually give a very small margin of 5 millimeters and replan the case every week to actually reduce the amount of dose that goes to the normal brain. Next, I want to touch on a bit of imaging advances. So as I mentioned, commonly we struggle with the question of, is this radiation necrosis or is this tumor progression? There are MRI techniques such as diffusion-weighted imaging, perfusion spectroscopy. At our institution, we use something called contrast clearance. So this is actually not a very high-tech technique. Essentially, it's looking at how well the lesion retains contrast over a period of time. And lesions that retain contrast, so we scan them at 5 minutes and again at 60 minutes. If the contrast is retained, we think this is more likely a necrotic process rather than tumor. We also use selectively functional imaging in glioma patients. So FDG PET scans are not very useful because the brain parenchyma takes up the tracer. But amino acid PET scans are useful for gliomas in particular to identify the exact location. And it's more useful in the post-treatment setting to see where exactly the tumor has recurred, and also to differentiate between recurrence and or tumor progression. Functional imaging is also useful in meningiomas. So in this situation, we use dotatate PET scans. So this is a patient with a skull-based meningioma. Most of the time, you assume it's going to be limited to the brain parenchyma, but he actually had extension to the infratemporal fossa. So the utility of dotatate PET was shown in this case, and we actually had to modify our treatment volumes. So I think the holy grail for neuro-oncology is if you can integrate PET and MRI, because these are the two more useful modalities. And now with the advent of PET MRI machines, this may be something that we can look forward to. So I'll move on to the molecular diagnosis of gliomas. So things like 1p19q and MGMT have been used in the past, and it's pretty standard now. But the WHO in 2021 redefined how gliomas are classified by the use of IDH mutation status. And IDH has also been used, IDH inhibitors have also been used as a potential tool to delay the progression of low-grade gliomas. So based on the Indigo trial, we know that if patients went on this vorasidenib drug, the progression-free survival was actually much more prolonged compared to if they were on placebos. So this may be a tool to actually use metabolic targeting for tumors that express IDH. And also in brain metastasis, we used to say that surgery and radiation are the only ways we can treat brain metastasis. But I think the landscape has changed quite a bit, especially for tumors like EGFR-mutated lung cancers. We often use osimertinib upfront for asymptomatic patients as a tool to manage brain metastasis, and it's quite useful because most of these patients also have extracranial disease. So it's a drug that addresses the body holistically. Similarly, for melanomas and HER2-positive breast cancers, we do have drugs as well which work pretty well and have good intracranial response. So in these situations, we can actually use drugs upfront and delay the use of radiation to when patients really need it. So coming back to the title of today's talk, Precision Oncology, Precision Care in Neuro-Oncology. So every discipline comes with their own lens of what precision care is. And I think it's our duty to actually integrate everything to provide the patients a personalized treatment plan. So for the last few minutes, I just want to touch on some of the ongoing studies we have at NUH and that we are quite excited about. So the first one is called a QPOP trial. So this actually stemmed from success in other cancers such as refractory lymphomas, where we found that if we did ex vivo drug sensitivity testing, we could actually cure some of these patients who were progressed through multiple lines of conventional chemotherapy. So the same concept was applied to gliomas. So we use a panel of drugs, both conventional chemotherapy agents as well as experimental agents. And during the time of surgery, the tumor is harvested and actually grown in the lab into an organoid. And it's actually exposed to these drugs at different concentrations. And basically, we look at the cell viability. It's similar to doing antibiotic sensitivity testing. But in this trial, we also exposed the sample to radiation and chemotherapy ex vivo to make them resistant to these drugs and see in the recurrent setting what drugs the patient will be susceptible to. So in this example, this is a 48-year-old lady with a primary glioblastoma who had a recurrence after about 17 months, which is very common. And we can see the common drugs that we would subject them to on a routine clinical care would be rechallenged temozolomide, maybe lomustine. And the dark red ones indicate that it's not effective at all. There's high cell viability. Whereas the ones in pink and in lighter shades were the ones that are cell death. We can see if we use a combination of drugs, the cell viability is much lower, particularly if we use higher doses of those drugs. So the QPOP has actually given us the opportunity to modify the kind of drugs that we use in the recurrent setting And we have seen some good responses in patients. So this is just a forest plot suggesting that in this patient, this is a cyclophosphamide and platinum-based agents actually had a better chance of controlling the tumor. Okay, in the last part, I just want to touch on this very exciting trial which will be starting in NUH in the next few months. So stem cell therapy has always been a buzz in neuro-oncology, but it's never really seen much clinical success. In this trial, what we did is we modified stem cells derived from adipose tissue. We actually made them express certain genes that actually convert a type of chemotherapy into active agent, 5-FU, within the brain. And the other novel thing about these stem cells is that they actually localize with the tumor. So they seek the tumor. Once they go to the tumor, they convert an inactive drug, 5-FC, into 5-FU within the tumor. The second thing that it does is that it also secretes interferon beta. So this activates a cGAS STING pathway and turns a cold tumor into a hot tumor. So it's sort of a dual-pronged approach that we are taking towards gliomas. And we actually have animal experiments to show that this has been quite successful in small animal studies, as you can see in this diagram here. And also we've done experiments on large animals, although not within the brain, but within other animals, animal tumors. They also had some success with this stem cell therapy. And we are about to launch our phase 1 study, where at the time of resection, the patient actually has removal of the tumor. The stem cells injected into the tumor cavity, and a tissue glue is applied around the area to sort of lock it in there. And the stem cells are expected to diffuse throughout the brain and seek out wherever the tumors are. And the patient will be given this oral 5-FC drug, which is actually inactive but activated within the brain. And we hope that this study will give us some good outcomes. So it's still phase 1, still early, but I think we're very excited about where this will take us. So just to conclude, for precision neuro-oncology, it has to be end-to-end precision, all the way starting from advanced imaging to image-guided surgery to better molecular diagnosis to high-precision RT and systemic therapy integration. But I think we should not lose our focus. Our goal should still be to prolong survival, preserve cognition, and individualized care. And whenever we have a multidisciplinary sort of integration of care, I think we need to have protocols to sort of shape our practice, and also care coordinators to help patients navigate the complex landscape. So with that, I'd like to thank you.